Okay, um, Dr. Hassan, let me just give you a brief introduction and then you come in. Good evening, members. It's exactly 6 p.m. and I'm just standing in big shoes today. Unfortunately, our host, Dr. Omar, is unable to be with us today. But regardless, we'll have that lecture go on. So I will start by introducing Dr. Hassan. She's called Dr. Jomana Hassan. She's a specialist in periodontology and implantology since 2011. She has 14 years clinical experience in her clinic and universities. She has been a supervisor in periodontal department in Syrian Ministry of Health, International University of Science and Technology, and Al-Rashid University for Science and Technology. Nowadays, she's a manager of a dental clinic in Al-Rashid University and responsible of clinical implantology procedures. Ladies and gentlemen, I give you Dr. Hassan. So I think you can unmute your mic and take on. The floor is yours, Doctor.
Thank you, Doctor. Hello, colleagues. I'm Dr. Jomana Hassan from Syria. Today, I want to produce this lecture about how to plan for successful implant. Nowadays, every dentist practice and should learn about implant in his clinic. I will give you in this lecture the criteria and main rules to plan for a successful implant. Let's start. Inserting implant is a simple and complex procedure in the same time. You make it simple by planning for it well to decrease complication as you can. Planning for implant takes more time than surgical inserting it. Maybe surgical inserting the implant takes a few minutes, but studying the case takes an hour. So we should study the case carefully to arrive to the surgical stage accurately. First, choose the correct patient. What's the meaning? Not all patients are candidates for implant procedure. How? There are some systemic disease, conditions, and habits affect the implant success called risk factors. Some of these risk factors are absolute contraindications for implants. First, uncontrolled diabetes. Uncontrolled diabetes happen when HbA1c more than 8%, and that affects the implant success by difficulty in wound healing, susceptibility to infection, impairment of neutrophil function. That means peri-implantitis and more infections about the implant, impaired osseous repair at the first stage, so that affect the osseointegration around the implant. So uncontrolled diabetes is absolute contraindication for implants. So smoking, other risk factor is smoking. Heavy smoking delays healing, causes osteoporosis, that decrease the contact surface between the implant and the bone and affect the stability of the implant in her location and its location. Heavy smoking associated with more plaque and with colonizing of pathogens impair several aspects of innate immune response. That means more infection and more failure. Impair PMNS, leukocytes, blood migration and chemotaxis, and that affect the immune response, decrease blood vessels, and cause vasoconstriction, and that affects the osseous repair. Commonly, patients must advise to stop smoking for successful implant for at least 4 weeks after procedure. Heavier smoking is or heavy smoking is relative contraindication for implant. Recent heart attack or stroke are life-threatening conditions during the first 6 months. Bleeding disorders also life-threatening conditions and should be managed and managed with consulting with the physician of the patient. Why? To avoid the complications during the surgery. Young age. Dental implants shouldn't be done for patients under 18 years old because of uncompleted jaw growth, and this affects the jaw and the position of the implant. So, patients who is under 18 years old are absolute contraindications for implant. Extensive alcohol and drug abuse. This can also impact the success of implant by affecting the healing. Alcohol and drug abuse cause osteoporosis, which affect the osteointegration of the implant. Osteoporosis and bisphosphonate. Both of them are very important conditions. We should notice about that and study the case very carefully. Osteoporosis is a condition which manifests by fragility bone. Smoking, alcohol intake, vitamin D deficiency, estrogen deficiency, postmenopause, parathyroid hormone disorders can cause osteoporosis. When the patients have osteoporosis, that means less surface contact between the bone and the implant, so that will affect the stability of the implant. So because of a fragility bone, implant will fail because of inadequate osteointegration. Here, healthy bone and osteoporotic bone. Look, white bone marrow, and when we put the implant, it will be less surface contact between bone and implant. Bisphosphonate is very important condition. It's very important medicine which is used to treat osteoporosis and metastatic of malignancy orally and intravenous, and which cause osteonecrosis, which American Academy of Maxillofacial Surgery called it MROMJ, that means medicine-related osteonecrosis of the jaw, and it happened after implant insertion or any surgery. Intravenous bisphosphonate is contraindication for dental implant. According to American Academy of Maxillofacial Surgery, individuals who have taken oral bisphosphonate for less than 4 years don't need any alteration in implant surgery. Only discontinuation of this drug should be considered at least 2 months. The study of Yip et al. Concluded discontinuation of oral therapy of bisphosphonate for 4 to 6 months. This picture shows bisphosphonate osteonecrosis. It's a late complication. It needs long time of treatment, long period of antibiotic like tetracycline, many times of debridement. It's very difficult case. Minkus, Sarah et al. Suggested that avoidance of dental implant procedures in patients that have been receiving intravenous bisphosphonate. There is no universal time to stop intravenous bisphosphonate before dental implant. Common recommendation is to have the procedure at least 6 months after last intravenous bisphosphonate. So ask your patient about the medicine he have taken it. History of radiation therapy of head and neck. Only the radiation therapy in these regions. Radiation therapy of head and neck would cause osteoradionecrosis and implant failure if absorbed dose more than 60 gray. According to Grant Storm, it's all Lindquist, up to 40% of implant failure rates have been reported in patients who have had history of radiation therapy. So radiation therapy affects the success of implant, which is old or new in the late or in the recent time. Implant procedure should be done at least 14 days before radiotherapy in some studies, and no accurate double time after radiation therapy. Six, another study concluded 9, another 12 months. Picture, it's all evaluated the survival rates for implant placed after and before radiotherapy and without radiotherapy and found the rates. After radiotherapy, survival rates was 80% to 100%. Before radiotherapy, survival rates was 89 to 97%. Without radiotherapy, survival rates was 92.2% to 100%. Chemotherapy of cancer. Patient who is under chemotherapy will be immunosuppressor, and the implant will fail. Drugs used for chemotherapy affect osteointegration and success of dental implants. With chemotherapy, chemotherapy is associated with more infections, more failure rate. Poor oral hygiene. Patient with poor oral hygiene is at high risk of peri-implantitis and failure. And we should change this bad habit in the patient by motivating him and learning him to maintain high level of plaque control. More plaque that's associated with more pathogens that cause peri-implantitis and periodontitis and failure of the implant. Previous history of periodontitis and treated periodontitis. Periodontitis susceptible patient may experience more complications and implant failure. So we should examine the patient, treat any periodontitis which is present in the mouth before any surgery. Bruxism, excessive occlusal loading increase the rate of screw losing. The screw is one part of the implant and may cause implant fracture. Using mouth guard may help. Psychiatric disorders. Patients with psychiatric disorders are uncooperative and don't maintain oral hygiene. They don't follow the instructions after the surgery. Psychiatric illness is absolute contraindication for implant. All these factors we spoke about it. We can know them and detect them during the clinical examination, which include cheap complaint because the treatment should be acceptable and suitable for the patient's expectation. Medical history give ideas, and we should report this about the systemic disease in the patient. Not only that risk factors, we spoke about them that affect the implant success, but only to avoid the systemic disease or manage the systemic disease that cause complications during the surgery. Oral hygiene habits, we spoke about it. History of tobacco, dental health. Next step, after a clinical examination, after recording the medical history, sheep complaint, oral hygiene habits, all this information, we start with intraoral examination. We will examine teeth, caries, lost teeth, bite registration, centric occlusal interarch space, and bite registration, centric occlusal interarch space help us to put a treatment plan that is suitable for the patient. Ridge mapping this is ridge mapping, and this is the instrument that used for that, which is called caliper. In ridge mapping, we detect the soft tissue thickness and the osseous defect at the ridge where we will put or insert the implant. We should examine gingiva, color, size, texture, bleeding to detect any gingivitis and treat it before the surgery, keratinized mucosa and implant reception site. Width and thickness of keratinized mucosa are very important factors in implant success. 2 mm thickness and width of keratinized mucosa are acquired for successful implant. Probing depth to detect any periodontitis, clinical attachment level, furcation involvement, tooth mobility, that to treat any problem before implant surgery. After we finish from intraoral examination, we start by radiographic examination. We have 3 kinds of radiograph are used in implant procedure. We will speak or talk about them. Let's start with intraoral radiography, periapical radiography. Can be used only to assess implant osteointegration in the second stage of surgery and during the surgery to be assured that the implant is inserted in the suitable location. Bite-wing radiography is rarely used, but we can use it to assess interdental bone during next to implant. Extraoral radiographic, panoramic radiography, most common in dental clinics, it shows teeth, intramandibular joint, mandibular impacted teeth, intraosseous lesion, lysis, and tumors. So it gives us a whole look of the jaws. But because of 2D magnification, superimposition of cervical spine and other structures, that decrease from its accuracy, and it's used only primarily in treatment planning, and we don't use it to choose the implant dimensions or location or anything. This is panoramic radiograph. Multi-detector computer topography is a kind of topography, high radiation dose, high cost, but it's more accurate, but it's not used in dental implants commonly. CBCT, beam computer topography, is essential in implantology. it's the kind of radiograph we depend on in choosing the dimensions and accurate location of the implant. Less radiation, more accurate, more used in implantology. Why? What can you study in CBCT? Anatomical structures like alveolar, mandibular canal, maxillary sinus, nasal fossa, mental foramen, lingual artery, sublingual artery. Third dimension, which is bacolingual width, shape of ridge, objective measurement of bone density, to evaluate residual bone height in a more accurate way, to choose the correct implant dimensions, extension of cyst and osteoid lesion, used in all specialization in dentistry, but we will talk about implantology. Here are some slices of CPCT. Look to the anatomical structures we can see. Here, foramen, mental foramen, which is the home of mental nerve. This is alveolar mandibular canal, which is the home of inferior mandibular nerve. This is the maxillary sinus. This is the home or location of sublingual artery. This is nasal fossa. This table shows the safe distances from anatomical structure when we insert the implant or preparing the canal of it. We should be far away 2 millimeters of alveolar mandibular canal to avoid damaging of nerve of inferior mandibular nerve which cause numbness. 2 millimeters coronally and 5 millimeters anteriorly from mental foramen. Also, to avoid damaging of mental nerve, which cause numbness of lower lip and anterior teeth. 1 millimeter from maxillary sinus to avoid perforation of Schneider membrane, 1 millimeter from nasal fossa and the anterior of maxillary, 1.5 and at least 1 millimeter from adjacent tooth. Less than 1 millimeter will damage the periodontal tissues around the natural teeth. 2 millimeter from the adjacent implant to avoid the damaging of osseointegration around the two implants. 1 millimeter buccal and equal surface of the implant side to avoid over eruption of the implant or overlocation buccal. After we finish studying the case by the examination clinically and radiography, we are ready for the surgical procedure. Surgical procedure needs some conditions to achieve successfully. First, implant should be sterile, and that's what implant system provided, and dentists save this sterilization. Implant site should be prepared under sterile conditions. Look at this picture and look to the infection control instructions. Sterile surgical gloves, sterile gown, sterile instrument, etc. Implant site should be prepared under atraumatic technique and good irrigation. Avoid overheating of food during preparation. Heat shouldn't during preparation. Heat shouldn't exceed 47 degrees for a minute. Implant should be placed with good initial stability. Their torque 35 Newton in centimeter. Implant should heal without loading or micro movement. Healing period is 3 to 4 months in the mandibular and 4 to 6 for maxilla. Good drills which provide automatic preparation. Common recommendation that drills are not used after 30 times, because after 30 times it will be dull, and we need to prepare the canal strictly, so it will give overheating for the bone. Infection controls, I learn instructions, I follow it and learn my students about that. It's important to finish the surgical procedure with the primary stability of implant figure. Primary stability is the time of surgery related to geometry of implant, macro design. Macro design, I will speak about it later, and bone quality and quantity. Secondary stability after mounted, after healing, and related to micro design, that means surface, type of surface, of implant and bone quality and quantity. Both of them are important for implant success. I will speak later about geometry and micro design. This table shows classification of bone density according to Hausfeld. There is 5 types of bone according to Hausfeld. G1, more than 1,250 Hausfeld, dense cortical bone. It's not preferable for implant because of less blood vessels. G2, 850 to 1,250 Hausfeld, thick dense superos, cortical bone on crest and core subclavicular bone. It is the most preferable type of bone for implant. D3, 350 to 850 Hausfeld, thin porous cortical bone on crest and fine subclavicular bone. G4, 150 to 360 Hausfeld, fine subclavicular bone, thin cortical bone, and wide bone marrow. This is the worst type for implant. G5 in nature, non-mineralized bone, and this is contraindication for implant. Where we see those types, or these types, D1 at the anterior mandibular region, D2 in the anterior or posterior, D3 in the posterior of mandibular or anterior of maxilla, G4 only in posterior mandibular, and maybe it is D3. In the anterior region of the mandibular, there is no vital structure, so it's the safest region for the implant. Now, there is a very important state, and I want you to learn about its implant system. When implant system distributors come to you the clinic and give you the catalog, and you open the catalog and you don't understand anything in it. It's too shame for you and for me. We should learn about all the details and characteristics of the implant. We should ask the distributors about the implant, and don't let them speak more than you. So I will learn you some details and characteristics and their relationship with the implant success. Let's start with case surface type. Proper implant surface have been shown to promote better bone to implant contact and higher success rate compared to machine smooth surface. Nowadays, all the implants in the companies are raw are have raw surface. Implant surface roughness first started with hydroxyapatite, then titanium plasma spray, then the most effective, which is titanium oxidase blasted acid etched XAA, and more recent etched anodized laser ablation. Our implant ICX, which is made in Germany, the ICX premium implant has a sandblasted and acid etched, that means SLA, sandblasted acid etched surface with an average roughness of 1 to 3 microns. It is still designed to promote good bone response. Size of implant, diameter and length. Implants with larger diameters generally achieve greater long-term success. Long implants also tend to have higher success rates. But not all the time and cases, we can insert implant with large diameter and long because we follow the residual bone height and width. The implant system should provide you all the diameter you need. But there is some rules. In posterior area, avoid to use the narrow implants or small implants, small diameter implants. They don't can resist the overloading or occlusal loading forces. Our implant ICX provide you all a group of diameters and length. Threads design. What is this thread? Threads. This is the threads of implant. And the developmental of the implant is at this three. There are three dimensions, are three parameters: the three pitch, three shape, and the three depth. They are more important about implant success. Pitch is the distance between the center of the thread to the center of the next thread. When pitch is less, that means the number of threads is more per unit of length. So more threads means more accuracy with the bone, more contact with the bone, and increased functional surface of implant which dissipate compressive load to implant bone contact. Other parameter is width, is the distance between the upper surface of the thread and lower surface. More width, that means more surface contact between bone and implant. Depth, it's the distance between the top of the thread to the surface of the implant. More depth, that means more contact, more surface between the implant and the bone. Our implant design, macro design, thread, and it provides a group that increase the surface contact between the implant and the bone and more distribution of the loading forces. Thread designed as V-shaped patterns, reverse patterns, and square. V-shaped, square, patterns, reverse patterns, and spiral. A study by Musavar demonstrated the superiority of square thread configuration for all degrees of osseointegration implant cortical bone transition region in the square thread. A study of Initua and Tapia concluded that maximum stress was located around the neck of the implant and the majority of the stress was distributed in the bone adjacent to the first thread. Our ICX implant start with the square thread, then V-shape with this group that increase the contact surface between the implant and the bone that promote osseointegration and more distribution of the loading forces. Connection type. Implant abutment connection means interface where implant and abutment meet. The two types of connections are external connection, external hexagon, older design where the implant sits on the top of the implant fixture, associated with greater marginal bone loss, micro movement of interface, and less bacterial seal. The most modern design is internal connection, internal hexagon, which is conical or frictional. Conical or friction. Or friction fit connection provide superior stability and better microbial seal and less bone loss and micro movement. External hexagon, internal conical, and that's called the switch off when the attachment diameter is less than the platform diameter, and that promotes osseointegration, emergency profile of soft tissue, bones, more bone bacteria, seal less movement of the attachment. This is internal frictional fit, friction fit. Active ICX implant has a more stable internal connection. Conical taper that is a self-locking conical connection that creates a tight, straight pre-unison between the implant and the abutment. So less micro movement, less bone loss, and less bacterial seal, and decrease the pathogen colonizing and micro movement. This is our active ICX implant and conical connection between the abutment and the implant fixture. A study of young men, John Bin Lee, which is published in Journal of Periodontal Implant 2022, demonstrated that after 1 year of losing marginal bone loss was greater around the implant with external abutment connection. The 5 details of implant, we should learn about it and play a role in implant success and osseointegration and distribution of loading forces. Each implant puller Implant cooler is a part of implant fixture which cover the neck. It has many shells: smooth, rough, divergent, convergent, straight, micro-threaded. The best is rough and micro-threaded because they are associated with less marginal bone loss. Our ICX implant is micro-threaded or rough. This type of the implant is tissue level, and this smooth part is over or above the bone. This is ICX implant, which its cooler is micro-threaded or rough. We choose the implant, we study the case, we do the surgery. At the end of the surgery, there is two types of the implant surgery. In one stage, implant surgery, the procedure finished by putting healing abutment. In two surgery stage procedure, we will finish by cover the screw, and embedded implant under mucosa. This is the first stage. In the second stage, we should make gingival incision and to expose the implant. But in this stage, I prefer to use gingival grafts, connected grafts or free gingival grafts, and many kinds of incision that increase the width and thickness of keratinized mucosa for their role in implant success. In the posterior maxillary region, I use this technique, which is called palatal roll technique, and helps me to increase the width and the thickness of the mucosa around the implant. This is in my clinic, and this is the result. Look at the soft tissue around the implant, color, thickness, and keratinized. Another case of palatal roll technique, and its result, thickness and keratinized, thick and keratinized mucosa around the implant. After that, we will start by prosthetic stage and also play an important role in survival rate of implant. Good processes mean long time to the implant to stay survival. To provide for the process, first, loading time. Usually, we talked about it. For maxilla, it needs 4 to 6 months. For mandibular, it needs 3 to 4 months. Immediate loading related to implant design. We spoke or talked about it, macro design, and bone density to provide adequate primary stability. Correct implantation. Polyvinyl siloxane or polyether are the best impression material for that. Direct open tray technique is the most accurate technique to the transfer coupling. Here, we use the plastic trays. We make holes facing the transfer. When we take it off the mouth, take it out of the mouth, we put this part, which are called analog. Analog is a part which represent the texture, implant texture or abutment in the cast. This is close tray transfer analog. Choosing the suitable procedures according to the case. Single crown or bridge. Screwed or cemented crown according to interocclusal space. When interocclusal space is less than 4 millimeters, we should use the screwed crown. When we have more than 4, we can use either screwed or cemented. Screwed is most preferable because of its advantages, but in the aesthetic area, it may need a special type of abutment. Fixed processes or remove processes. Oh yeah, that means overdentures according to the number of implants in a dental arch. For removable processes, we need 2 implants at minimum in mandibular and 4 for maxilla. For fixed processes, we need 4 implants at minimum in mandibular and 6 for maxilla. This is healing abutment. Fixed. We have 6 implants in the lower jaw. All accessories should be provided for good process. This is the accessories of our implant ICX, healing abutment, transfer for closed tray, impression, transfer cupping for direct and open impression. We have multi-unit abutment, zirconia abutment for the anterior region, and a straight abutment. Implant follow-up. To have high survival rate of implant, we should put the patient in follow-up program after prosthetic stage. First year, every 3 to months after year, if the patient without any risk factors like bad oral hygiene, tobacco, alcohol, diabetes, if the patient without any risk factor, every 6 months, if with risk factors, it could be every 2 to 3 months. Evaluation of dental implant by probing to detect bleeding on a probing depth to detect any peri-implantitis and treat it. And examination of keratinized mucosa and periapical photograph to assess the osteointegration and bone height around the implant. Assess the oral hygiene of the patient. 1 to 2 millimeters bone resorption is acceptable in the first year and 0.1 millimeter after the first year annually. Thank you for your listening, colleagues. I hope I give you benefits, and I want to tell you that I will be with you in a course 2 to 3 days before, 2 to 3 days before symposium. If you want to be with me, contact Dr. Tamoh to register your name. And the course has theory and hands-on practice. I wish I saw you all next month. Thank you. And now, is there any question? I'm ready for that.
Doctor, there are some questions in the chat.
Yes, okay. Yes, implants are absolutely contraindication under 18 years because it affects the jaw growth and the position of the implant will change. So we put provisional process until 18 years, and then we go insert implants for the patient. What the difference was sounding and bone mapping? Yes. What's the differences between bone sounding and bone mapping? Is the same. Bone sounding can be made by the probe under anesthesia by the probe. Bone mapping is done at the ridge and implant siting location or implant location. Bone sounding can be done in every or around any natural teeth. You talked about stopping bisphosphonate about 6-12 months before any surgery. What are the implications if taken after replacing the implant? When it's safe, after how long stay in post-menopausal? After how long? After replacing the implant, the patient can take it after months. No accurate time is recommended, but in some studies they say 6 months. Say in post-menopausal women. Okay. Is the implant analog used only on screw retained or even cement retained implant? And the two implant analog represent of the implant texture or the attachment, the top of the implant or the attachment in the cast laboratory. So it's used with screwed or cemented retained implant. Any question? Any question?